Hello, this is Geneva Briggs. The topic for this program is calming the flames of menopause. I have no actual or potential conflicts related to this program other than being a woman who's nearing menopause. Menopause happens to every woman if she is fortunate enough to survive to middle adulthood. Every woman experiences menopause in a unique way, but many do seek help in managing the various manifestations, especially hot flashes. This program focuses on the ins and outs of recommending various supplements that can be used in managing menopause. So we're going to focus on non-prescription supplements. I will spend just a small amount of time on the prescription options to give you a feel for where they fit into all this. We'll start out going over what is perimenopause and actual menopause, what are the problematic symptoms that women seek help for. Then we'll talk about each of the supplements, efficacy, dosing. Are there any special adverse effects you need to worry about? Are there cautions you need to take into consideration? We'll finish up with a case study, and I hope at the end you get a feel for what supplements likely work for what symptoms and what does not work. First, we need a few definitions, so we're all on the same page. I think the most important thing to say about menopause is it is not a disease. It is a natural phase of life. Unlike our other endocrine glands, which function lifelong, our ovaries are programmed to shut down at a certain point. The word menopause literally means end of monthly cycles. So menopause is the permanent cessation of ovulation and menses. Perimenopause is the time from which menses start to become irregular until 1 year after the final menstrual period, which menopause is technically that final menstrual period. Unfortunately, you can't actually identify the actual date of menopause until 12 months has passed, because you have to see that a woman has not had a menses for a full 12 months to say they are truly in menopause. The next two slides, I think, help explain this better, what is really meant by menopause. Women experience several stages of reproductive aging. As you can see on this slide, you have the reproductive years, the early, peak, and late reproductive years. During this time, a woman pretty much has regular menstrual cycles. You can see in the late years of this, FSH, follicle stimulating hormone, begins to increase. The next slide shows you the menopausal transition stages and the post-menopause stages. You'll notice at the 0 point is that final menstrual period, which is technically menopause. Now, most women refer to the whole phase of perimenopause as menopause. Perimenopause runs from that early menopause transitional stage through 1 year after the final menstrual period. You can see that this is variable, how long it takes to go through perimenopause. Women begin to notice differences in their cycle. They start varying in length. Then late in this menopausal transition, they begin to have missed cycles, greater than 60-day periods of amenorrhea. FSH is very high during this time, and estrogen levels are beginning to decline. Once that last period has occurred and a woman enters the postmenopausal phase, you have natural cessation of estradiol and progesterone production from the ovaries. Reproduction is no longer possible. The postmenopause phase continues on until a woman's death. You'll notice during this time, FSH levels are still very high if you actually measure them. Now, after menopause, remember that estrogen does continue to be produced at low levels in other tissues. Hundreds of years ago, menopause was not a big concern. Women typically lived to be about age 50, and the average age of menopause was 51. Today, the average age of menopause is still 51, but life expectancy is 80 years. The age of natural menopause in Western countries ranges from about 42 to 58 years. You sometimes see wider ranges published of 40 to 61, but the majority of women will go through menopause between the ages of 42 and 58. The average age of menopause is different for other countries. Women now spend many, many years in that postmenopausal phase. Interestingly, on average, women who smoke cigarettes experience menopause 2 years earlier than non-smokers. That's yet another reason to encourage people to stop smoking. Women can have premature menopause, and that is defined as menopause before the age of 40, usually labeled as primary ovarian insufficiency. You do see a lot of cases of induced menopause because of chemotherapy, radiation, or surgical removal of the ovaries, usually for treatment of breast cancer. But people may have gotten chemotherapy for some other reason that caused them to go through menopause. One point here about induced menopause. Natural menopause occurs gradually. So women experience declines in estrogen levels gradually over several years before they actually enter menopause. Whereas when you take someone's ovaries out, they have immediate, abrupt development of menopausal symptoms because they lose that ovarian estrogen all at once. Women who have induced menopause can have very severe symptoms. The most common menopause-related discomfort that women complain about is the hot flash, sometimes called the hot flush. Night sweats are hot flashes with drenching sweats that wake up people during sleep. So that's what distinguishes a night sweat from a hot flash. Low levels of estrogen during perimenopause and postmenopausally are thought to be related to hot flashes. Now, one hypothesis suggests that these decreasing estrogen levels may affect the norepinephrine and serotonin systems in the hypothalamus, which is responsible for thermoregulation. As a hot flash develops, skin temperature, cutaneous blood flow, and heart rate all increase. Many women complain of a sensation of heat that starts in their head or upper body, and they can even have reddening of the skin and actual flush, followed by sweating, and then they may actually even feel a chill after the hot flash has passed. Night sweats often result in sleep disturbances. They wake people up, they have to change their sheets, then they have trouble getting back to sleep. These night sweats are then thought to contribute to some of the other common menopausal complaints like fatigue, irritability, anxiety, insomnia, etc. More than 2/3 of North American women have hot flashes during perimenopause. Women, of course, as I mentioned before, with surgical menopause often have severe hot flashes that begin immediately after surgery and last longer than those in women reaching menopause naturally. The typical duration of vasomotor symptoms is 3 to 5 years, but they can last longer. You will encounter some women who are in their 80s who still have an occasional hot flash. I've even encountered a few women who pretty consistently have hot flashes throughout their lifetime. Well, not really their lifetime, during their postmenopausal lifetime. One important point here is that menopause is not the only cause of hot flashes. Other medical conditions, such as thyroid disease, some infections, or very rarely cancer, can lead to hot flashes, particularly night sweats. Additionally, remember that some medications, such as, of course, tamoxifen for cancer, raloxifene, Avista for osteoporosis, and niacin can all cause hot flashes. Thus, women should not assume their hot flashes are always menopause related. They really need to see a healthcare provider to rule out other potential causes, particularly if menopause doesn't seem likely because of their age, or if a woman has other unusual symptoms, anything that might suggest another reason for those hot flashes. Women can also experience many different non-vasomotor symptoms. these may or may not be related to actual menopause. They can just be due to aging. They may also be due to life changes or stressors that typically occur during middle age. So there can be a lot of other reasons for many of these symptoms. Now, some of the non-vasomotor symptoms may be secondary to those. Hot flashes and night sweats causing disturbed sleep or causing anxiety during the day. Others are probably related to low estrogen levels, like the urogenital issues, vaginal dryness, painful intercourse, urinary incontinence. Those all seem to be related to decreasing estrogen levels. Also, skin and hair changes you see. Now, there are issues that also occur during this phase in life because of changing balance of estrogen to testosterone. Women tend to see extra hair in places they don't really want it. They see weight gain around the middle instead of around the hips and thighs. Lifestyle modifications are the first step in managing menopausal symptoms. Women who are overweight with BMIs greater than 30 are more than twice as likely to experience moderate to severe hot flashes compared to women whose BMI is less than 25 or considered normal. Weight loss can be helpful in some women. The other thing about this menopausal phase of life is women do find this is a time where they begin to gain weight, even if they haven't already during the rest of adulthood. Because as we age, our metabolic rate tends to decline. You're also in the phase of life where you might be exercising less. So women, even if they don't need weight loss, during perimenopause, they probably will find that they need to begin to do some things to avoid gaining weight. Cigarette smoking increases the frequency and severity of hot flashes. So you can recommend smoking cessation for those who smoke. Exercise is also helpful in managing menopausal symptoms, and a healthy diet. Stress reduction is another thing that can be helpful for some women. All these lifestyle changes decrease menopausal symptoms. They increase a woman's sense of well-being, and they lower her risk for cardiovascular disease, breast cancer, and osteoporosis. Once someone has gone through menopause, their risk for developing cardiovascular disease, breast cancer, and osteoporosis all go up. There are some specific lifestyle modifications for dealing with hot flashes. Many women can identify certain triggers, such as alcohol, hot or spicy foods, caffeine, stress, hot drinks, or a warm environment. They can identify a specific trigger, then they can change and no longer be exposed to that trigger. Another thing is staying cool, particularly if a warm environment, especially at night, leads to hot flashes. Wearing moisture wicking fabrics, layering clothes and bedclothes so they can strip things off easily. One big thing is trying to keep your head cool. Putting a cold pack or a chilled pillow under your regular pillow so that you can just flip your pillow back and forth to always have a cool side. Of course, fans, air conditionings. So poor spouses have to layer up themselves to try to stay warm when they're living with a woman enduring hot flashes. Relaxation training can help some women. Paced respirations or paced breathing. That utilizes slow, deep abdominal breathing when they feel a hot flash coming on. When someone's taught how to do it, it's been shown to reduce hot flash symptom duration and frequency. After all the bad press hormone replacement therapy has gotten, lots of women and their healthcare providers are searching for alternative ways to manage menopause. But even before the big studies that came out that identified problems with long-term hormone replacement therapy, many women were using natural products to treat their menopausal symptoms. According to the National Business Journal, sales of supplements for menopause relief grew 4% annually between 2000 and 2008 to a total of $334 million a year. Now, I couldn't find any sales figures since 2008, but I would say they have continued to climb. In studies, 46 to 48% of women surveyed use some type of menopause supplement with or without hormone replacement therapy. Only 54% of them reported their use to their primary care provider. Like many other supplements, people don't think of them as drugs. Women tend to think of these menopausal supplements as safer than hormone replacement therapy, and that may or may not be true depending on the particular supplement. We can divide treatments that work for menopausal symptoms into those that affect hormones and those that don't. The hormonal options either replace natural estrogen or they act like estrogen. Since the release of the Women's Health Initiative and the HERS studies on hormone replacement therapy, the use of prescription hormone replacement therapy has been controversial. Those studies found that conjugated estrogens plus medroxyprogesterone increased the risk of heart attack, stroke, venous thromboembolism, and breast cancer slightly. Since HERS, other studies have also found other concerns about an increased risk of dementia and urinary incontinence with hormone replacement therapy. Hormone replacement therapy still has a place, but it's no longer considered a drug for all reasons. It's now only recommended short term for controlling menopausal symptoms. And as we talk about each of the supplement agents, think in your mind comparing it to hormone replacement therapy, because HRT really is the most effective way to reduce hot flashes and those other non-vasomotor symptoms in most women. You see at least a 75% decrease in frequency and severity of hot flashes with hormone replacement therapy compared to placebo. The non-prescription supplement options that are considered hormonal agents are phytoestrogens, black cohosh, and DHEA. So we're going to talk about each of those. An important point before we start talking about these is there is a huge placebo response in controlled trials for hot flashes and other menopausal symptoms. You see up to 40 to 50% placebo response rate in these trials. Some of them even higher, some less, but on average, let's say 40% placebo response. The most commonly used group of natural products for vasomotor symptoms are phytoestrogens, or the so-called plant estrogens. There are three major classes of plant chemicals that have estrogen-like actions in the body. These are lignans, isoflavones, and coumestans. Lignans are the main phytoestrogens present in Western diets. Isoflavones are the most potent and the most common phytoestrogens in supplements. Phytoestrogens are not structurally related to estrogen, but they contain a phenolic ring that allows them to bind to estrogen receptors. Phytoestrogens are 100 to 10,000 times weaker than endogenous estrogen. Depending on the tissue type and the location in the body, phytoestrogens can act as estrogens or antiestrogens. For example, the estrogenic activity of soy varies with the level of endogenous estrogens. In premenopausal women with normal endogenous estrogen levels, soy phytoestrogens have an anti-estrogen effect since they can displace endogenous estrogen from the receptors. That's why we think they might have protective effects against endometrial and breast cancer because they're minimizing estrogen exposure. In postmenopausal women with low endogenous estrogens, soy phytoestrogens are more likely to act as weak estrogens, so bind to the receptor and have physiologic effect. Interest in phytoestrogens for vasomotor symptoms began when people noticed that only about 10% of Asian women experienced hot flashes, and the Asian diet contains significantly more soy isoflavones than the typical North American diet. Studies have found soy, either from food or supplements, is modestly effective in relieving hot flashes. 34 to 76 milligrams of soy protein a day, or 35 to 120 milligrams of soy isoflavones through a supplement. You will notice here there is some negative data. About 5 negative trials have shown that soy is no better than placebo. There have been several other trials that have shown positive results. One example here is with 30 milligrams a day of genistein, which is a particular isoflavone, decreased hot flash frequency 51% compared to 30% with a placebo. Another trial used 120 milligrams a day of isoflavones, and in that particular trial, that was equivalent to 0.625 a day of Premarin. There's lots of speculation in the literature about why there are inconsistent results with all the various soy trials in treating menopausal symptoms. One reason is that in some of the trials, they have a very, very high placebo response, more than what you would even expect. So it's hard with a high placebo response to really show that an intervention is actually better than placebo. Overall, in the trials that have used at least 15 milligrams of genistein per day, consistently show modest positive outcomes for hot flashes, but not necessarily other symptoms. Soy seems to be best for hot flashes, not many of the other symptoms. Listed on this slide are just 3 examples of widely available soy products that, according to ConsumerLab.com testing, contain at least 15 milligrams of genistein in the recommended daily dose for those particular supplements. For postmenopausal women, there are also bone benefits in decreasing bone loss for consuming soy in the recommended amounts. The most accessible sources of genistein in our diet are soy milk or roasted soybeans have the highest content. The web address on this slide is for an excellent fact sheet on genistein. I included it here because it has a table with a listing of foods and their typical content. Flax seeds may help some women with mild menopause symptoms. They are a good source of lignans. However, not all studies have shown these benefits in relieving hot flashes, and the studies are all very small. Flaxseed oil is not effective because typically it contains little or no lignans because the lignans are bound to fiber. Some specially processed flaxseed oils have lignans added back in after the oil's processed. 40 grams of flaxseed per day, which is approximately 4 tablespoons full, appears to be the effective dose based on the small trials. Important thing to note about that, 4 tablespoons is 16 grams of fat and 200 calories, so people need to substitute it for other fats in their diet. Red clover is another popular phytoestrogen. This primarily contains biochanin A and enformononetin. Probably not pronouncing that even close to correct. Red clover supplements contain very little genistein. Now, the body can convert biochanin into genistein. 5 controlled trials with red clover found no consistent or conclusive evidence that red clover leaf extract reduces hot flashes. There have been 2 positive trials using 80 milligrams a day. Almost all the published trials have actually used the promensal product. No major adverse effects have been reported with using red clover. The one concern is if patients are using the 80 milligrams a day or anything higher than that. If they're on any anticoagulants or antiplatelet agents, they may have issues with bleeding because red clover contains coumarins. 1 promensal tablet contains 15.6 milligrams of biochanin A. I can't find anywhere a factor of how much biochanin the body converts 2 genistein. So I can't tell you that 15.6 milligrams of biochanin equals 15 milligrams of genistein. It probably doesn't because of the 5 negative trials with this. They used pretty much one tablet of Promensil a day. It may take 2 tablets a day to get enough. That's that 80 milligram a day dose. People want to try red clover. They can try it 1 a day. If that's not effective, they could go up to 2 a day. But again, small trials needed 80 milligrams a day to appear to get positive response. There are some cautions with isoflavones because they can act like estrogens. In the vitamins and lifestyle trial, the VITAL trial, which looked at supplement use in women over several years, did not find an increase in risk of breast cancer with the use of phytoestrogens. Now that's in all women. It is recommended that women with a family history of breast cancer or estrogen positive breast cancer themselves, that they should avoid supplements and excess consumption of foods containing phytoestrogens. There's also been a few studies that have looked at issues with soy and red clover interfering with the effectiveness of tamoxifen and aromatase inhibitors in treating breast cancer. In those cases, women should avoid these supplements and excess consumption, of course, of foods. What about the endometrium? Because hormone replacement therapy can be an issue there. Long-term use of soy from diet or supplements at low to moderate doses doesn't seem to be a problem. But long-term use of a concentrated supplement that had 150 milligrams a day of soy isoflavones for 5 years did stimulate endometrial hyperplasia. So it's probably best not to do supplements, especially at higher doses, for long term. Probably 2 to 3 years at the most is probably effective for managing menopausal symptoms. After that point, women should begin to come off of them. Now, you don't seem to have issues with it in diet because people don't tend to consume excess phytoestrogens. Black cohosh is another very popular supplement for menopause symptoms in the U.S. Remifemin, a branded black cohosh product, has been used in Germany since the mid-1950s to manage menopause. Black cohosh was also used as the main ingredient in Lydia Pinkham's vegetable compound, if you have interest in old-timey medicines. We don't know exactly what the mechanism of action of black cohosh is. Sometimes it's listed as a phytoestrogen. More recent studies are looking at it as a SERM, a selective estrogen receptor modifier like tamoxifen or raloxifene. In experimental models, it seems to have estrogenic activity in some tissue types, such as the bone and the vagina, but not in others, like the endometrium or the breast. Black cohosh may also act as a partial agonist at serotonin receptors, which may be why it works for hot flashes. There have been 5 negative trials that have compared black cohosh to placebo. In addition to those 5 negative trials, there have been at least 6 positive studies looking at a specific product, the isopropanoic black cohosh extract, that's been standardized to 1 milligram of triterpene glycosides per day. And that's the actual Remifemin product. And sorry, I said 1 milligram per day. It's 1 milligram per 20 milligrams because the recommended dose is actually 40 milligrams a day, so 2 milligrams of triterpene per day. The effective dose of black cohosh appears to be 40 to 80 milligrams a day, aiming to get 2 to 4 milligrams of triterpene glycosides a day. It does take some time for black cohosh to be effective, and I didn't mention this before, but also for the phytoestrogens it takes time. Usually someone should give it at least 6 weeks, maybe up to 12 weeks of a trial. What I recommend is with black cohosh is that women start with 40 milligrams a day, go for 6 weeks, see if they see a decrease in their hot flashes and other symptoms. If they do, but it's not as effective as they would hope, they could go up to 80 milligrams a day. I don't recommend going beyond 80 milligrams a day because that's where you begin to see some adverse event reports of liver toxicity. There have been greater than 30 case reports of increased liver enzymes, some cases of liver failure and death, autoimmune hepatitis. Now, we don't know for sure that it's caused by the black cohosh. If someone taking black cohosh develops symptoms of liver trouble such as new abdominal pain, dark urine, or jaundice, they need to stop the black cohosh and be seen. Some people do recommend that when using black cohosh that women get at least baseline LFTs before they start, and then periodic monitoring of their liver function. Other minor adverse effects you see with black cohosh: GI upset, rash, headache, dizziness, weight gain, those kinds of things. Seems to be fairly well tolerated. If patients are on other hepatotoxic agents, such as statins, other agents, or on cisplatin chemotherapy, they need to avoid black cohosh. In consumerlab.com testing, one black cohosh product, Nature's Way, was found to be contaminated with low levels of lead. The lead in this, in and of itself, shouldn't be a problem, but it just is unnecessary exposure for people. And this is a product that was made from root powder instead of a root extract, which may account for the lead. In the extracting process, usually products don't have lead contamination. Another study was published looking at black cohosh products, and there may be a problem with adulteration. 1/3 of the products in that study tested were adulterated with Asian Acineta species, which have a different chemical composition than American black cohosh roots. That study found a very wide variability in composition. Unfortunately, consumerlab.com did not test for triterpene glycosides in their testing. So the only product that I know of out there that has a standardized triterpene glycoside content is the Remifemin product. Now we can move on to talk about other commonly used agents with a lot less data. DHEA, of course, is hyped as a miracle hormone to prevent aging. Natural levels of DHEA do drop in our bodies after the age of 30, and it's a precursor to our sex steroids such as testosterone and estrogen. But the hype far exceeds the research for using it for menopausal symptoms. Small trials have found increases in estrogen with DHEA supplementation, with modest decreases in hot flashes and improvements in other symptoms. The issue with DHEA is essentially you're giving low-dose unopposed estrogen, which is the same as doing hormone replacement therapy. Since DHEA also increases testosterone, it can lead to some unwanted adverse effects. Taking Panax ginseng doesn't seem to help vasomotor symptoms in postmenopausal women. Some preliminary research does suggest that ginseng might improve quality of life and menopausal symptoms such as fatigue, insomnia, and depression compared to placebo, but it's very small trials, very little data to say that you get a significant impact with the ginseng. Chase tree or chase berry is another agent that is many times classified as a phytoestrogen, but its effects probably are more likely from a dopaminergic activity. It appears effective for PMS and premenstrual dysphoric disorder. The only trial I could find published in menopause found that it actually didn't have any benefit for hot flashes. Now, a subset of patients with more PMS-like symptoms did appear to benefit from chaste tree. Relatively minor adverse effects with this. Typical dosing, at least for PMS and PMDD, is 20 to 40 milligrams a day. Chaste tree has been studied for up to 1.5 years and doesn't appear to increase risk of breast cancer or endometrial hyperplasia, but most sources you will read will recommend that women with an estrogen-positive breast cancer avoid using chaste tree. In addition to agents that work through a hormonal mechanism, centrally acting agents have been studied for vasomotor symptoms and for general managing other symptoms. These agents are especially indicated for women in whom hormone replacement therapy is contraindicated. Clonidine, 0.1 milligrams a day, gabapentin, 900 milligrams a day, the SSRIs and the SNRIs at low doses have all been shown in a few trials each to reduce the frequency and severity of hot flashes. Now, they're not as good as hormone replacement therapy, but probably would be a choice after someone who doesn't want to do hormone replacement therapy. If they're trying some of the supplements and those are not working, then maybe one of these agents would be a reasonable choice. One point with any of the prescription agents listed here or hormone replacement therapy, when women try to stop them, they can find that they have a rebound in their hot flashes. So all of these need to be tapered off slowly in order to prevent that rebound. Two supplements that have been studied that are thought to be centrally acting options are St. John's wort and kava. St. John's wort has been studied in at least 5 trials in menopause. 3 of those were in combination with black cohosh, found to be effective in decreasing menopause rating scale ratings. That's an overall rating of all symptoms and number of hot flashes. And also found to decrease Hamilton depression scores because it works for mild depression. Alone, it may not be terribly effective for reducing hot flashes. The role for St. John's wort in menopause appears to be for mood-related symptoms. It doesn't appear alone to be very great for hot flashes. The dose that's been used is 300 milligrams 3 times a day. The big thing to remember, of course, about St. John's wort is it has a tremendous number of drug interactions, and I have only listed just a few here. Kava is another agent that has been studied at least in 1 trial, primarily for mood-related symptoms of menopause. But because of the issues with hepatotoxicity and liver failure, it is best to avoid using kava. The next slide lists several agents that, although they're commonly found in many menopausal supplement combination products and are heavily promoted for such purpose, have all been found to not be effective in reducing hot flashes or other symptoms of menopause. Wild yam or Mexican yam is one that's heavily promoted to be used topically. The thing about topical application is the body actually cannot convert daidzein from wild yam into progesterone, which is what the promoters will say about it. Daidzein can be converted in a laboratory into progesterone, but the body cannot do it. The next slide lists several supplements that are commonly found in multi-ingredient menopausal products, but have not specifically been studied for menopausal symptoms. One note, valerian and hops have both been used for sleep and can be helpful for that, but don't have any effect on hot flashes. There are a ton of different products out there that are targeted at women for managing menopausal symptoms, and a lot of them have a lot of useless stuff in them. I just picked out a few of the more widely available ones and put a picture on here along with the ingredients so you could see what the active ingredients are in them. My preference is to choose a product with a single source ingredient. So just genistein or just a black cohosh product. Now, kind of hard to find those. Women can start with either soy or black cohosh, depending on what other things they have going on about estrogen-based cancers and stuff. They can try it for 6 weeks. If they're seeing some benefit, they can continue for another 6 weeks and reevaluate. If the first one chosen doesn't work, then try the other one. And something to note about the Remafemin and Estroven products is there are a lot of different products with that same name. There's ones targeted that add ingredients to target sleep or mood or energy. The two I listed here are the ones that have the fewest ingredients. How's that? I don't have an issue with the products that add multivitamins in there because that's particularly if a woman typically takes a multivitamin every day, they can combine that with their soy isoflavone or their black cohosh. The thing about the estrogen product here listed here, it has both black cohosh and soy isoflavones in it. Good dose, sounds reasonable. The thing is, the only study out there that's looked at giving that combination together found that it's no better than placebo. So I don't know if they cancel each other out. Who knows what's going on? Whether that's actually, we only have one study to look at. So I don't know if there's really benefit in doing a combination. The only place I would recommend the combination of doing those two is if someone's tried black cohosh by itself, it didn't work. Then they tried soy by itself and it didn't work. Or they got some benefit but not a huge amount. Maybe they could try the combination and see if it works. But I wouldn't have an expectation that it would work if either single ingredient had not worked. When a woman asks for your help in managing her menopausal symptoms, it's also a good time to review other health issues like calcium and vitamin D intake. So making sure that women over 51 are taking 1,200 milligrams a day of calcium and vitamin D. To also look at their other cardiovascular risk factors. Is it time to begin looking at their cholesterol, their exercise, their smoking, their blood pressure, all those other things, because they increase risk of developing heart disease after menopause and other preventive health issues. Are they getting mammograms? Are they still getting pap smears? What's their vaccination status? What about when supplements fail? So someone's tried the over-the-counter stuff and they're still having major issues with hot flashes or one of the other menopausal symptoms. Well, the first question I would ask, is this problem really menopausal? So maybe they need a general health checkup to see if they really are menopausal or if something else is going on. Depression is something you have to look for. Depression is very common in the perimenopausal period, and they may not actually need to be treated for that. Not just an antidepressant at a low dose for their hot flashes, but they may actually have a full-blown depression that needs to be treated. Over-the-counter stuff doesn't work. They can consider hormone replacement therapy for a short period of time, get things under control, begin to feel better, and then taper it off. Or the non-hormonal Rx options, the low-dose antidepressant or the clonidine or gabapentin. Those are all options. The next slide just lists some resources for additional information. All these resources also have some very good patient education handouts. Let's now finish up with a case study. Anna's a 49-year-old who asked what you would recommend for difficulty sleeping. After you talk to her for a while, you realize that the issue is probably night sweats. She also is having 4 or 5 hot flashes during the day, but hadn't really connected that with her problem sleeping. She's had a recent mammogram and pap smear that were okay, no family history of breast cancer, and denies any depressive symptoms. So what are the options for her to manage her hot flashes? Of course, lifestyle changes. You can talk to her about doing those things. Then beginning to look at one of the supplements if she's interested in that. they're truly bothersome, she may want to investigate hormone replacement therapy. Because she doesn't have a history of breast cancer, any of the options we've talked about, with soy and black cohosh probably being the more effective of the supplements. Because of concerns about the safety of hormone replacement therapy, many more women are turning to natural products for menopausal symptoms. There are many things out there that are not effective. Of course, the two that may be effective in women with no history of estrogen-related cancers are black cohosh and soy or red clover, trying to look at getting at least 15 milligrams a day of genistein. Even with the over-the-counter things, they probably need to be short-term, 1 to 2 years at the most, and then begin to taper them off and see if someone still needs them, because the safety data we have says that at least using black cohosh for up to a year and soy isoflavones up to 2 years at moderate doses doesn't seem to increase risk of breast cancer or endometrial cancer in most women. Again, if they've got a history of an estrogen-related cancer, their only option that I feel safe with is going with a non-hormonal prescription option, referring them to someone for prescribing something like that.